I remember. It's incredible. Let me just tell you what we're going to do here. I'm going to ask everybody to make sure that you're on mute so that we can just do this with clarity. Albert has a little presentation to start us off with. This is definitely going to be a meeting where we're going to do a lot of talking together because this is a time for you to bring questions that you have to Albert, who really is our world expert on ML4. But first, we have some really exciting news. The ML4 Foundation has received a tremendous funding grant of about $2.4 million. And that funding is going to do several things for us, but the largest bucket of that money is going to fund Albert Misko to conduct clinical research. As you know, that has been a real gap in our program, that we've developed a lot of information on preclinical research to understand how a gene therapy works in the mice and is going to be successful, but we haven't had enough funding in clinical research. And this award that we have just successfully achieved is going to fund Albert to pursue this research. So we're extraordinarily excited. It's going to do a lot to advance our program. And so I wanted Albert to be able to share what this means. And since it's entirely focused on you guys, let him do some explaining about that and let you guys ask some questions about that. Does that work for you, Albert?
Yeah, I just have 4 short slides to sort of bring everyone up to date. I'm just going to share my screen now.
Yeah, you should be able to share, I think.
Awesome. Nope, that is not it. Again, what's going on? Do you see the presentation?
I do. I see it like in PowerPoint. I see your gene therapy crossing the finish line slide.
Yeah, I put that up first.
There you go.
Great. Okay, wonderful. Thank you. So as Rebecca had mentioned, we've been tirelessly with Julia just trying to find another industry sponsor or another way to bring the treatment that Julia has developed into clinical trials and to you guys. That's the ultimate goal, is how fast can we get it to all of the patients and test whether or not it's really going to be efficacious. And a huge part of that, a huge driving factor for all of these industry sponsors that we've talked to, is the fact that all of you are so engaged and so motivated to find a cure for this disease. And I can't stress that enough. It really is just like the driving force behind this, and why industry sponsors are willing to consider this and really are excited about the project. And the preclinical part has gone really well with Julia developing the gene therapy. And you guys have seen a lot of data on this in the mice and how it's going. And it's really bringing us to the next step of hopefully trying this in a clinical trial with the ultimate goal of obtaining FDA approval. And what I want to stress here is that FDA approval means gene therapy for all patients. And that's the ultimate goal, to get here as quickly as possible so that we can treat every single patient in this community. Now, there's a lot of hurdles along the way that we've been addressing to get there. And one of the biggest ones is to convince the FDA that we can demonstrate the efficacy of this treatment in patients, and that's really reliant on natural history, so that it goes hand in hand. They're tied completely together. And it's been extremely hard for us to get funding for natural history because it's something the NIH just doesn't really go for. It's not sexy, it's very expensive. And the fact that Rebecca was able to secure this funding for it is just tremendous. Because what it means is that we're going to be able to move forward with pretty much the missing part of the puzzle here. Now, how is that going to help us, like, step by step? Well, there's a few little hurdles that we have to go over, or meetings with the FDA in order to get to the clinical trial. And we've been doing pretty good in making progress, and most of them are dependent, the very first one, on the preclinical development, but we've gotten a lot of that done. And the other steps are very dependent on the natural history, and that's included the cross-sectional, which we've already done, and have helped us get to this Interact meeting, which we're planning in the very near future. The next step will be this pre-IND meeting, It's just going to be very dependent on the retrospective data, which I'm going to talk to you about how we're going forward with now that we have this new funding. And then finally, the prospective too. And all of this is going to come together to really help get this industry sponsor to take us through to the finish line, to the very end. Because to get through the clinical trial, to produce the actual vector or the gene therapy itself, you need someone in industry to do this. And the motivation, again, the further we get along this pathway, the more readily industry sponsors are to sign on. So every step along the way is getting us closer and closer. And this is like a huge part of this. So now, thank you all of you guys who have participated in the retrospective to date. We've had some really good successes with it, but mostly related to funding. We've had some really big challenges as well. And I just want to point those out and how everything is about to change drastically for us. So at first, I'm so appreciative because our approach it necessitated putting all the burden on the families. And you guys have done such an amazing job collecting all of these records, but it also required you to go out and find the records at all of these institutions. And I know that took a lot of work. Also, when we get those records as PDF formats, they're not searchable, they're not indexed, and it takes a ton of time to go through them. It's actually very laborious and extremely hard. And we've been working on ways to make that better and better. We also didn't have any means of translating this. In fact, Rebecca was helping us find volunteers to try to translate these records. And that's awesome. But the problems are that the FDA looks at that and they say, hey, wait a minute, those aren't official medical translators. We have issues with the fact about data integrity. Even if they're translated correctly, it doesn't matter. They want to see that there's a stamp of approval on everyone that's been doing this. And along the same lines, they require having data monitors all along the way checking this study. But that too requires money. It's something that can be done through the MGH and the NCRI, but again, we'd have to actually engage these people, data monitors, and now we can. So things are about to change drastically. And the first way we're about to do that with the new funding is that there is a company that I've worked with in other studies for other disorders called Telegenesis. And they're going to do the data collection for us, or the record collection for us. So because this is such a drastic change, it does require me to write a whole new protocol, an IRB protocol. And what that is an ethics committee approving my study. We have to kind of say at this point, because this is going to be such a drastic change, that it's kind of starting fresh. But so you guys know, this is not a setback. We're not losing anything. We're moving forward based on everything that we've learned from the retrospective so far. We're just about to supercharge it. This company, Telegenesis, what we'll be able to do is, after we can reconsent all of you guys back into the study, because you have to say it's okay for us to do this with this new company, we're going to give you a secret code. You're going to go to their website and start entering in information just about every physician that you've ever seen. And the company is going to go out and they're going to collect all medical records from all institutions that you indicate. They'll put it together in a very special type of PDF that's searchable, that's indexed for us. And what I mean by that is that it's arranged chronologically, and we can click on links to get to all the data that we need. And they will also automatically extract data for us from the PDFs. This is just going to put us light years ahead of where we are now. And even better, that PDF is something that each of you get. So finally, we're able to give you back something as well, and that you'll have a complete package of all of your child's medical records that are searchable, printable, and you can bring them to any other medical professional that you ever see in the future. So you have everything together in one place. And I think that's going to be extremely valuable. The other things that we're going to be able to do are have an actual translation service. We're going to take all of those records that are in Hebrew, French, and other languages and officially translate them over so that the FDA recognizes that this is usable data that can be put towards the future clinical trial. And that's going to be extremely important because so many of our patients come from around the world and we can't lose out on that data. It's so valuable. We need every piece of it that we can get our hands on. And then finally, we've learned so much working with other industry partners up to now about all of the regulatory stuff that goes into assuring that the FDA says, hey, yes, you can use this data for a clinical trial. And we've already built in all of those checks and balances, and we're ready to engage them and put them into this study as we start this new chapter. So I hope you guys are as excited as I am about this, because it is going to require us calling you again and getting you re-enrolled in this new chapter, which is going to take about, so you guys know, from now, I expect about 1 or 2 months for that ethics committee bouncing back and forth with us about checks and balances, ensuring that we're keeping data safe and secure and the way that we're contacting you is appropriate. But right after they approve us, it's going to be, it's going to be a rush. It's going to be a blitz. We're going to contact everyone. We're going to get you all enrolled and get this off the ground immediately because the clock is ticking. We've got a lot to do. And we have a very important meeting with the FDA coming up in the new year at the very beginning of the new year. And we're going to need this data for that meeting. So this is all starting again. And again, all thanks to you guys and your participation and Rebecca securing this amazing funding. Now, this funding is also allowed for another chapter of natural history, something called a prospective natural history. And what this means is instead of going back and collecting records, which has been extremely, extremely important because it allows us to get data from patients across the whole age spectrum from across the world, right? We're able to go ahead and sample tons and tons of data. The prospective is going to be something where we actually bring patients to MGH and we start doing testing on those patients, clinical characterization, maybe imaging studies, and trying to collect data. Now, the thing with the prospective, which you're probably already guessing is, one, wow, very expensive, right? Because you actually have to fly people, we have to do testing and that sort of thing. Two, it's also cumbersome for families. It requires you to actually pick up and travel. So it has to be done on a much, much smaller cohort of patients. And we're trying to strategize on how to do this appropriately. Now, part of the way that we've been pitching the gene therapy to companies, and what we believe from our data, from Yulia's data, is that we're going to see an improvement in function with gene therapy. And this is not a traditional trial. I want to point that out. Most gene therapies are looking to stop a functional decline in patients. And so its endpoints are something either pretty morbid, like stopping death at survival, or it's something just very obvious because patients get so bad so fast. If they can still walk, then that's just unheard of and the treatment must work. Our challenge is a little bit unique. And I think it's actually really, really cool. It's that we're going to show that our patients, our kids, are at a baseline, their functional baseline. And with treatment, we're hoping there's an inflection point where they improve. But that's what's going to require here is that we really establish what their baseline function is. And there can be variation, there can be fluctuation. So it's going to be very important to get at least 1 year of data on kids to show what that baseline function is so that after treatment, we can see if it changes or not. And we're in the middle of designing this. We have to figure out what the inclusion and exclusion criteria are going to be, meaning what patients or how do we strategize to get this clinical trial off the ground and completed as quickly as possible. And we're not exactly sure completely, but some of the thoughts that have included that we have to consider are when we talk to the FDA, what age ranges are they going to want to see this in? Sometimes they don't want you to dose the youngest kids first. They want older kids because they think it's a little bit safer. We also have to consider how do we decrease the amount of time this clinical trial takes so that we can, if we get approval, we can get this to the whole population immediately. That may mean biasing this towards some of the younger patients who may just show faster improvement. Actually, the FDA wants you to do this within a year or two anyway, very quickly. And if we can prove efficacy as fast as possible, that means we can get this to everybody. And so we're still strategizing. We don't know the answers yet, but we're getting closer. And this is in the near future as well. And so I don't want to take any more time up from this. I just hope I leave you with a lot of motivation to get engaged in this retrospective natural history again, because it's going to be totally different. We're going to be able to give you something back, and it's going to really bring us through this FDA meeting that we're going to have early in 2022, which is just going to be pivotal, both for securing our industry sponsor and actually just for the design, the way that we go forward. Once we know what their responses are to the way that we're thinking about how to approach this clinical trial, we can start reshaping or continuing what we're doing right and changing what perhaps the FDA wants us to do a different way. All right, great, thank you.
Thanks a million, Albert. Before we go to questions that people have about, each of your own children, I do want to take a couple minutes and see what questions you might have about everything that Albert has just shared. You can do that either by raising your hand. If you see that at the bottom, there's a reactions button where you can raise a hand like I just raised in my screen, or as Amnon did, just put a question into the chat. And I'll start with Amnon's question, which Albert is, can MGH cooperate with international hospitals for a study? For example, can we test a child in Tel Aviv and send relevant data? So do you want to explain about single versus site?
Gosh, that's such a good question. Okay, so first let's talk about like very large studies that necessitate a multiple center study. So when you're doing drugs for things like blood pressure, heart disease, cancer, things that, your trial is going to involve hundreds to thousands of people, it absolutely necessitates multiple centers. Now, there's a lot of challenges that go into that though, because testing has to be standardized across those centers, meaning that if you take a brain image at one center, that's a totally different scanner and a totally different team of specialists that are looking at that compared to another center. And so a lot of times there's a lot of money and a lot of effort that goes into centralizing the measures. That means standardizing how things are done at different centers. And then usually even then the data is all sent to one place to only be interpreted in one place so that there's no biases or differences between centers. That's only really possible when you have hundreds and hundreds of patients that are involved in a study. Because ML4 is so rare, we're not going to have the ability to account for those variations between centers when it's only a handful of patients. And as such, the FDA is going to want us to do this all in one place. And honestly, that's, even though it is a large burden on the families, scientifically, it really is the only way to do this right, to be honest with you. And they're wanting us to do that is the correct way to do it. So we're going to have to, for the prospective study and what would happen in an actual trial would be that the company, or if we have the funding, we would pay for the travel. We would bring you here. We would pay for you to stay here, receive the treatment, and undergo all the testing. But it would have to be done in one place, unfortunately. We are working on trying to develop remote assessments too, but because they're so experimental, and this is new for everyone in the field, they don't take the place of the in-person evaluations. Those still need to happen in Boston. But great question.
Yeah. And we're really paying a lot of attention to what the tests are that need to be done and the sequencing of them to make the experience. And we will certainly be speaking, with you about that, one that takes into account the amount of time that, you would be in Boston, given the distances that some of you may be traveling. We are giving thought to this issue. Other questions about the information that Albert just shared?
Oh, I see something in the chat, Rebecca, and I can address that. Actually, for the retrospective, no, we want patients of all ages, not just up to 16. We want everyone. We would love those medical records. However, you don't have to send them. And this is the beautiful thing. We're going to get you guys re-enrolled, and this company, Telegenesis, is going to take that off of your hands with the translation as well. And even if you do have translated records, remember, it's not just about, now it's about dealing with the FDA. It's about following proper procedures and protocols. So when they come back and audit us, they see that everything has been done in a certain way that they can account for and understand. So thank you so much for offering to send those, but let's get you re-enrolled. We'll get Telegenesis to reach out and get all of those amazing medical records. We'll get them translated by someone that the FDA, I'm not saying that the translations you have are wrong. I'm just saying that the FDA wants to know that they were done by someone that has been met their qualifications. And we'll use every single record that you can send us, or that we get through Telegenesis from you. So thank you.
I want to get to John and then to Lauren. I want to emphasize as strongly as possible, the retrospective, even the reconsented retrospective that Albert's talking to, is everyone. We want every person involved. The bigger and the more robust the number of people we get in that, even if you've never given us information for the retrospective, join in now. The bigger that the number of people we have involved for the retrospective, the better our whole set of data is. So help in there. John, you had a comment or
Yeah,
question.
real quick. Very good presentation, Albert. No questions whatsoever. Just want to take the opportunity to make sure that I'm sure I speak for everybody to say thank y'all very much for all the work you've done, and going from a month or so ago where we had, I guess, some medical groups or testing groups pulling out on us, to securing the 2.4 million and getting the plan going forward and in record time. So thank y'all for everything you have done and continue to do for us.
Thank you, John. Thank you very much. I'm going to ask Lauren's question because it may pertain to some other people. I know the Combs have been working to come and visit you in Boston, Albert. And while the arrangements for that may be, singular to them, the question is, they submitted, some information about coming to visit. The question is that on hold given some of these changes?
No, sorry, the clinical visits are separate. And so you can think of those differently. If you come to see me in Boston just as a patient, that's like going to see your doctor. And even though we may do some research stuff while I see you, it's totally separate. So you don't have to worry about that.
Okay, so we need to tag up on that because I think that's been delayed, the processing of that visit.
Yes, we will catch up.
Okay. So Paula is asking, so is all the medical data sent to you from the NIH not used or valid anymore?
Oh gosh, so let me reset here. All of the data that you've sent us so far has allowed us to build the program that we have now. The design of our databases, the methods that we have to extract them, the scales that we designed to do the extraction are all made possible because of everything that you've sent us, and it's been amazing. Now, when we go to get this data again through this new venue, one, I want to assure you that's not going to take any, it won't be a burden on you, because I hope it'll be very minimal. All you'll have to do is indicate where your patient or your child was seen, and Telegenesis will go out and get these records for us in a very, very sort of like way where the PDF is easy to search, it's easy to extract data. And it'll be something, again, that the FDA can go back through and can say, okay, I know where this came from. I know how this was done. You can use it for the clinical trial. As of right now, they have to come back and they say, okay, how was this emailed? When was it collected? How do we know that this came from the right places? It's not that it's not valid. It's just that when we do it again this new way, it's going to secure the integrity of this data and allow us to use it for the clinical trial in a way that no one can question it. Let me put it, I think that's the best way to say this. We're just making sure no one can question us.
Is it fair to say then, I think in understanding Paula's question, that certain information that's already been acquired for our current use is going to be reacquired? And it's just that it's going to be reacquired in addition to any information that maybe hasn't been acquired in a manner that is FDA approved. That's really what
I think that's a good way of saying it. Yes,
yeah.
Definitely.
Yeah.
Thank you.
So don't worry, Paula, that data that you spent many years schlepping to the NIH to go and get is not going to be used. It's been used. It's been invaluable to get us where we are. We're now going, including Dr. Schiffman's data, Zvi Freund just put in, any data out there, whether it's been used already and been invaluable to Albert, or whether it has not been acquired, is going to be acquired through Telegenesis. It's just that it's going to be acquired without a pound of flesh coming from you. And it's going to be acquired in a way that is legal to the FDA so that it's going to be much more powerful for us. That's the story on why we're using this new format. So Monica was asking, can I grant access to her medical records instead of sending in the PDF? You will not be sending in the PDF. And you will be granting access through basically this portal. Telegenesis, we're going to basically give you a code. You're going to go in, you're going to tell us who you've seen. And then the company that we're paying is going to go and find all those records. So you don't have to be sending and finding and scanning and doing in all the way, excuse me, that you have been. Their job is to do it, and to do it in a way that is sort of legal in terms of the FDA. And we can actually go into the details of all of this. We can probably do like a little quick video or something on the actual mechanism of this when we get to that point in about 2.5 or 3 months or so, to make that even clearer. But I think the point for now is everyone should plan to do it. When I call you to set up meetings to reconsent, you'll say, yes, right away. I'd love to. And then we'll all, be back in business doing this, but it'll be a lot easier for you. Is telegenesis able to contact doctors as well as hospitals? Yes, anyone your child has ever seen. Going forward, is there any information that you'd like to see added? I'm constantly asked by our metabolic doctor, what do you want or need? That's a great question, Albert. Is there any information that you feel like maybe you're not getting, but that you'd like, if...
Yes, so the most helpful thing from us, from the natural history perspective, is getting very good descriptions of your child's function at any given time when they're seen in clinic. And that for your doctor, that means a full documented exam where they take the time to really write down everything that they're seeing in terms of your child's neurological function. Everything from language to gross motor function and fine motor function, their ability to take care of themselves or not take care of themselves at home. Every single detail documented that you can provide is extremely helpful. So that, I think, would be number one, way up here, is full descriptions and very detailed exams. And then the next down is just any lab work that you get for complications that your child might be experiencing, like the iron deficiency anemia that a lot of kids with ML4 develop, is very helpful. If gastrin levels are drawn, we'd love to see gastrin levels and any other lab work. But really, number one, far and above everything, is full descriptions of your child's function at the time when they go see your doctor.
And that's because we're applying a rating scale to the right. So Albert has created, unique to ML4, among other things, a ML4 specific rating scale. So you should know, and you can even say to your doctor, when these records come in, Albert as a neurologist is trying to apply a rating scale to these records. If there's no really detailed description of function in your child, that can't be done with a level of detail and sophistication. But if your neurologist takes time to really do that, we can glean information about how your child is functioning at that point in time. Question from Sasha. From early on, they had a Bailey's test, which showed behavioral ability. Is that something they should push to have done again?
Those types of neuropsychological tests they can be very informative. And for my own patients that are in Boston, I usually get those done every 2 to 3 years, as insurance allows. Now, I will say that there is some, they're not perfect for kids who have visual impairment. And because a lot of these scales are built thinking that kids have normal vision, sometimes they're not as helpful, unfortunately, as they could be in other circumstances. But what I would say is that if your insurance is covering it, it's no extra burden to you. It could provide actual good information just on how to help your child on a day-to-day basis. And so, yeah, periodic neuropsychological assessments are part of my normal practice. And if your physician is on board with it, that's definitely something to pursue.
Do you want to see like IEP psychological evaluations from school districts?
Oh, yes, those are fantastic as well. If you guys have IEP core evaluations, usually those have a lot of really good, helpful information in them as well. And that also would be extremely appreciated, definitely.
Super.
And that's something that telegenesis actually might not grab. So I'll have to talk to them about that. We can plan.
Right, yeah. Do you want dental records?
Ooh, that's something I haven't really thought of. Is there a general consensus in the community? Are there a lot of, so let me preface this with, so having dental caries or dental issues is not unusual just across a lot of neurodevelopmental conditions in which kids can't really handle their saliva. So a lot of the health of your teeth is there because, you and I might not think about this, but our teeth are constantly bathed in saliva and we're moving that saliva around. We're removing food from our teeth with our tongue because we have good lateral tongue movement and good articulation of our tongue. And so in neurodevelopmental conditions where that's not happening, dental cavities are not uncommon. And I would expect that would probably be the case too, just in our kids as well. Let's see, I mean, it could be interesting. Yeah, maybe there are things that we don't understand or know about. So sure, we will add those two, absolutely too. And I think telegenicists should be able to get those. That should not be a problem.
Okay. If someone's not regularly seeing a neurologist, is that something that you think they should, I mean, they see you occasionally, but is that something you would recommend on a kind of annual or some other basis?
I definitely recommend that. I'm a bit biased as a neurologist, but I definitely recommend an annual trip to a neurologist. So if you come to see me, I work with Brian Wishart, and you've seen Dr. Wishart on previous family meetings. And basically what will happen is, I do the full neurological assessment, and I think about how the nervous system is functioning correctly or incorrectly. And then I work with Brian, who thinks about, well, what supportive measures can we take to try to improve the function of the nervous system? And that could be physical therapy, it could be splints, it could be Botox injections. He and I talk about different medications that we can use in collaboration to help improve things like muscle tone. So I do think seeing a neurologist on a yearly basis is a fantastic idea.
That's great. Some people need for a PCP, like a statement, that would be helpful for you, of just describing what you need, like kind of in terms of just a description of functional skills, or like some kind of a statement guiding them. Is that something?
Yeah. Oh, that's a great idea. Let me write that down.
Yeah,
Maybe that's something we could even put up on the ML4 website.
that
and
would be
stuff.
great.
And
Yeah,
that's great.
Like when you go to your doctor, here's what to bring, to ask them for, because I think that specificity could really help people, both in terms of any potential tests to run. People are always asking, like that question again was like, wait, is it cystatin C that we should have tested, and at what age? Like just a checklist, I think would be really helpful for us to put together.
Great.
Let's see, we're getting a lot of comments here about, I think a lot of people are maybe not seeing neurology regularly because the neurologists, I think out there, and people could correct me if I'm wrong, tend to say like, kind of cut their shoulders. But I think if there is more specificity that we could give people as a guide, it would probably be really helpful. Sandy is asking, what about information from therapists? Because I think one of the things, paradoxically, because the kids are basically well, they don't see doctors as often, but they sure see therapists. And so if we could, glean from those sorts of records, or if you had a sense of what you wanted from those, that could also be potentially very helpful.
Telegenesis will collect physical therapy records, and physical therapists and occupational therapists tend to document fantastically, like way better than the physicians. So we get a ton of information from those examinations and those records. So yes,
okay,
those are really helpful.
Okay, that's great. Okay, what else, guys? Do you have specific questions about something that maybe is going on with your child that you'd like? These are great overall, and I see that these are coming out of the kind of what do we collect sphere, but does anyone have, Simonica, do you have something that you'd like to ask?
Yes, hi.
Hi.
I'd like to, I'm sorry, I took my video off. Here we go. Now you can see me. My question is, my child does not have any kind of iron deficiency. However, this is something very important. So I was wondering, because in Brazil, we have very little information regarding ML4, if I should add to her, despite the fact that she doesn't have any iron deficiency, supply her with supplements.
I'm going to say no to the iron, and let me tell you why. Is because we don't completely understand how iron is being used in the ML4 kids. Because so the channel TRPML1, right, that protein that's mutated or changed in the disease, inside of the cell, it's important for the utilization of iron. And so even if we give kids a lot of iron, we don't necessarily know if they're going to be able to use it. Well, then why do we give it to the kids with iron deficiency anemia? Well, because it's the best that we have. It's the best. It's the only thing we know what to do. So if you have iron deficiency anemia, and I've seen some of the labs, from the retrospective data that you all have sent us, and it can get pretty low, that iron level. I think it's absolutely appropriate to supplement those kids, hoping that their bodies will be able to use it and treat that iron deficiency anemia. And from the records that we have seen some people who have clearly responded to it, and it seems to work, and that's fantastic. But if you don't have that iron deficiency, there's not a reason to supplement it. I don't think it's going to help or boost function or anything of that nature, because it's not something that's missing. It's something that's probably just not being utilized appropriately, and flooding the system with it won't change that.
Okay, thank you very much.
Yeah.
John?
Excuse me. Yeah, just a couple things, not really questions, just bring up some points to see if they're common or want to investigate them further. But you had mentioned the dental. I know Lake has had, she had, and I know this happens outside of ML4 too, but she had either low or very little enamel on her teeth. So we had to do some coatings, especially for her baby teeth. It's not quite as bad now, but it's still not up to normal. So that was one issue. We'll send you, of course, she's been to a pediatric dentist for a good while, so we've got good records on that. As we talked a little bit about before, Lake's got pretty bad scoliosis now. So we're going to have surgery for that. Again, I don't know if that's something more common or less common with the tone issues and the lack of movement in some of the children. We've got her now on to that same point, we have her now on a baclofen pump, which is easier getting the medication to her. It also uses a little less amount. Seems to be helping with her tone issues, getting her ready in case we really need it after the surgery. And then the last thing that, besides the obvious issues that we all have, is eating. She was eating very well, extremely well, and it really went downhill fast about a year ago. And so she's on a G tube now, and that's pretty much, she's almost 100% on the tube, not eating much at all. So that's kind of where she is now. One thing, I guess, though, the eye things, whatever the heck we decide that is, those have tended to, those have reduced. Not that they're never there, but where we were having 1-2 a day several years ago, now, we might go a week and only have a couple of them. So that's been good.
Thank you, John.
Yeah. Does anyone else have those enamel issues? That's really interesting.
I don't know how to do this. Yeah, we haven't had, Rachel, we haven't had it. I don't know that we was ever diagnosed as an enamel issue, but for sure when she was younger, she had what they called soft teeth, which could be that. And she was getting cavities, even needing some root canals. Of course, she had to go under anesthesia to get them taken care of. But I have to say, since her grown-up teeth have come in, we've actually, knock on wood, been cavity free for quite some time. So I don't know if she outgrew it or what have you, but definitely when she was younger, we experienced the same. And I was also going to say, with regard to the iron, because we've been doing a little experimenting here, Rachel had low levels when we went to the hematologist, and they were saying, like, let's try a pill, before we go, obviously, right, for an infusion, hoping that her body would absorb the iron. And it did, and her levels went up, and we were up to, I think, 2 pills a day. And then her levels were, I'll call them perfect. So then we decided to dial back on the iron, and we just got our blood work back last week. So within 6 months, she had no iron, and her levels definitely started to go back down. So now we're going to start her back on 1 pill a day and kind of watch it. But so her body's absorbing it, I guess, which is the good news. We never had to go to the infusions, but definitely it's not like because I think someone, I don't know if it was Alyssa or someone in the past said their child took the iron and then they sort of stabilized and then they were good from there on out. But we definitely saw her go back down now that she's been off of it. So, just And we have all that new blood work because we also just did her blood work and we got her gastrin levels tested and all that good stuff that you guys told us to get to make sure we got with the, not just the cystathine, but the creatinine or whatever that is. So we got all that done. So I'll be sending you the report. I just got in the mail yesterday.
Great. Thank you. And Lauren, when the iron supplementation was started, did the hemoglobin and hematocrit, those are the measures of red blood cells, the actual anemia, that's low levels of those is what is consistent with anemia. Did those improve too with iron supplementation?
I'm gonna say I have no idea. I don't even, I'm also gonna say, if that's not like something that they routinely test for, then I probably didn't even ask. So I'd have to look, on the blood work to see, but I'm happy, like we'll probably get her tested again. And now that she's back down, her level, it's not as low as it was, but now that it's back down, we'll probably get her tested, again in another few months. I could, of course, add that to the battery of blood, but I'll look, what's it called? Can you type it into the comments so that I know to look on my thing to see?
Yeah,
okay.
I guess another way of asking them, your doctors is just, did the anemia go away when you supplemented with iron?
Yes, I'm not sure. I mean, I don't, maybe not, but whatever happened, reversed. So.
Okay.
Yeah.
Also, Albert, I'm just going to note before we move on to other issues that there are quite a number of people in the chat saying soft teeth, enamel issues.
Yeah. Okay.
So I do think getting dental is going to be illustrative for us, of at least
definitely
some early pattern. I want to ask a couple other questions that there have been. Sasha's asking a question about finger sucking. I know this has been present with a couple kids. I'm seeing Caroline raising her hand here and just thinking, oh my goodness, she's singing my song. Sasha says, my son keeps sucking his fingers. It happens after eating lunch until nighttime. I'm wondering if it's some sort of indigestion problem. He often burps as well. Could this be ML4 related, maybe to do with stomach acid? I know this is true for a couple of the kids. I see some heads nodding, and some people have had different hypotheses about this. It's been talked about in the chat. Sometimes when it gets started, it is a really, really persistent habit. Like kids will sometimes suck their fingers until they blister. So just any thoughts that you might have about this, or maybe other parents have about this.
Interesting. It's gosh, yeah. I mean, there are things that you can do to protect the fingers and stuff, like gloves or splints to stop it from happening. No specific medical interventions. It's usually just therapies and behavioral redirection. Okay. But I bet the people in this room are more expert on that than I. Yeah. They'll have better ideas.
Yeah. Okay. I don't know if Margie.
Sorry, can I just say, with the finger sucking, Rose was just doing it a minute ago. And I think sometimes it seems for her, it's also when she has food in her mouth, it's almost like she's trying to help it. I don't know if she knows that, but it's almost a bit of that, or just like almost like a bit of comfort, because she still will suck her thumb often. And just that she kind of, I think, likes how it feels or something. That's what it seems like to me. A little bit of food stuff and a little bit of just comfort and having it there.
Okay. Rainey's asking, Zinette has been having these occasions when she goes pale and looks like she's going to faint. She's getting blood work on the 5th. Any thoughts about what this might be?
Oh, interesting. Yeah. So the first thing goes to the iron deficiency anemia and your red blood cells. So anemia is low red blood cells. Your red blood cells carry oxygen to all different parts of your body. And so if you have anemia and low red blood cells, your oxygen carrying capacity is low or decreased. And that can definitely lead to fatigue, fainting, paleness, sweating, elevated heart rate. All of those things are symptoms of having severe anemia. So that's one possibility. Now, if you came to me outside of the context of ML4, the other thing that is, with fainting spells can be something called syncope, or a decrease in your blood pressure, or maybe another way to say it is the ineffectiveness to really circulate that blood around your body. And that's due to something called your autonomic nervous system. This is the part of your nervous system that does things that you don't think about. It controls things like your heart rate, your intestinal motility, your blood pressure, and all those kinds of things. And sometimes it doesn't work exactly right, and you can get these episodes of fainting. The way to treat that is usually increasing fluid intake, like water intake and salt intake. I don't know that the autonomic nervous system is affected in ML4. And from all the patient records that you guys have sent me, which has been wonderful, we've not seen any descriptions really pop up in on any of those that were concerning for compromise of the autonomic nervous system. So I think the right way to approach it then is to tell your PCP that, you know, it's not something outside of the iron deficiency anemia, which should be looked at first. This should be worked up just like it should for anyone else, because there's nothing specific about ML4 that jumps out that what might be causing that. And things that they might do, like I would do for any other patient that came in to see me, would be like EKG or an echocardiogram to look at the heart rate. I'd probably do blood pressures, both in the laying, sitting, and assisted standing position to see how the heart rate and the blood pressure changes. And then I would make decisions based on those initial findings.
Thank you.
Autonomic.
Hey, Joel. Joel, do you think we could I wanted to get to a question having to do with oral motor function. Paula is mentioning, and then I think I also missed, I think Sandy has a hand up, and I will get to Sandy in just a minute. Thank you. Paula is mentioning that her son is having some oral motor function decline, chewing, lip closure, and increased drooling. In addition to oral motor therapy, do you recommend medication to control the drooling?
That's a great question. So common medications that might be used would include a scopolamine patch, which is a little patch that would probably be put behind the ear, or another medication called Rubinol. And those two medications can be used to help decrease some of the saliva. The other option you have that's local, which I really like, are atropine drops. And so atropine, which you can use to like dilate your eyes, those same drops can also be put under the tongue, and that can stop some of the excess salivation. I do like that because it tends to stay local in the mouth and not go to the other parts of the body, even though to some extent it can get absorbed into the circulation. The Rubinol and scopolamine are great options, but they do circulate throughout the body, so you can get other side effects. The danger to those medications mostly are that if you dry up the saliva too much, it ends up becoming like, you know, gummy or thick, and then you can have even more problems just because instead of it being excess liquid secretions, it becomes like you know, you're gunking up the system. You can either choke on it or it can really gum stuff up. But if you find the right balance, it can be very helpful.
But it also affects urination, doesn't it?
The Rubinol and the scopolamine can, because they act on that autonomic nervous system. That is correct. So just like Benadryl or any of those medications that have some of these side effects, yeah, it can. But again, that's a side effect at higher doses. And what you want is like those lower doses, which is helping with the salivation, but not causing any of those unwanted systemic side effects.
There's a question about frequent sore throats. The Wellies find that their daughter has frequent sore throats and are asking if there's any relevance for ML4.
Oh, interesting. Nothing jumps to mind immediately. Do we know by any chance, is it more infectious? Has there been a workup to see if there are infections? Have they had a scope to see if there are ulcerations or other things going on, or do we know the cause?
Do you guys want to comment?
No, we didn't.
Okay.
I'll keep that in mind though. If I hear it from other families, like we can look into that.
Thank you.
Sandy, did you want to ask your question?
Yeah, I want to, Samantha's last blood tests, there was a B12 deficiency. Now she eats really well. She has a great range of food and that's never been low. So this was low. So we've been giving her some B12 injections, but we haven't retested yet because it's got to be over a few months. But I just want to ask if anyone else has had low B12 or if you know.
I want to respond to that, but first I want to hear if anyone else has low B12. Sandy, thank you for bringing this up. That's
No,
very interesting.
no.
Okay. So Sandy, going through everyone's records that I've had.
Nadine is commenting that Sarah also had B12 and was treated with injections. Nadine, did it remedy the situation?
Yes, definitely. She had injections once a week.
I inject
Yeah, but for how long? Once a week for
for
about 3 months or something, and it definitely made a difference.
Long term, you haven't had to redo that?
No, we haven't had. Since then, it's been okay.
Okay, thank you.
Okay. So going through everyone's records again, we've been pulling out lab data left and right. We haven't found anyone, at least in our records that we've had, with low B12. But that's actually mind-blowing to me. I thought everyone was going to have low B12. And the reason for that is that the way your body absorbs it. So B12 is absorbed. It interacts with a molecule called intrinsic factor that's secreted in your stomach. And in order for that to happen appropriately, your stomach has to be at a low acidic pH, or at least that's the common teaching. And all of our kids have this achlorhydria, which is low stomach acid, and that's a direct result of ML4. It's also why iron isn't being absorbed appropriately or easily into the intestines and into the circulation of our patients. So the fact that B12 was making it in was really odd and something that I haven't understood. I talked to Dr. Schiffman a lot about that too. It's kind of interesting.
Natalie just commented that JAKs are also low. It may be that we don't have enough
lab
data. Interesting.
Very interesting. Yeah, no, we'll keep looking into that. But if your B12 is low, definitely treat it. Definitely get injections or supplementation.
Wow, interesting.
Thank you.
Zvi, you've had a hand up.
Yes, we were talking before about drooling. We never followed this up, but somebody had suggested putting some kind of prosthesis on the top of the mouth, which would make the tongue touch it and rotate it, and that would cause the swallowing of the saliva.
Huh.
We never followed up on it, but we were wondering if anybody else was given that suggestion.
Oh,
Not familiar with that.
Sounds very interesting though. If you have information on it, I'd love to see it if you want to email it our way.
We don't. We just heard it.
Interesting.
Yeah.
Let's go ahead and mute again. Zvi, if you don't mind. Okay, other questions? Joel is back. I want to make sure that I have everybody's. If I've missed you, don't be shy about reposting or raising a hand. Okay. Paula has asked a question. I'm going to get to two things. Apparently, there is a branch of Boston Children's Hospital in Westchester. Is there benefit to taking her son there, and would they see him since he's not pediatric?
I'm sorry, it's Boston Children's in Westchester.
Apparently. Neuro and ophthalmology have offices in Westchester, New York.
Yes, hi, it's in Hawthorne, New York. We took Paul to an optometrist there, and in the complex, it says Boston Children's Hospital, pediatric neurology and ophthalmology, not pediatric ophthalmology, just ophthalmology. So my question is, if we went there, would you consider that as part of the clinical trial, if they did any
Oh.
sort of ERG or
I see.
retinal studies, or, that's
Yeah.
my,
Yeah,
should I
know
bother?
it's a little confusing. So we're actually not part of Boston Children's. They're a separate institution, which makes no sense. But we're at Massachusetts General Hospital. Yeah,
Right.
and there's like these. Even though we're all Harvard, there's some weird. It's not the physicians, it's the business people or whatever.
Okay.
There's all these. We can't even see their medical records. So they
Oh.
don't even share their medical records with us. I will say though, however, just for clinical care, it's a great place. And if you are looking for an ophthalmologist and, a neurologist, that would be a fantastic place to go.
Okay, thank you. It's just that Dr. Fulton, I thought was Boston Children's.
She is. She's not.
Okay.
Yeah, she is. And
Okay.
I can't see her records. We have to through research protocol send her stuff. It's ridiculous, but yeah.
It's not
Okay.
that. Two more questions. There has been some concern just because of individuals who have passed away about liver and kidney complications at the end of life. And there's a question about how to, guard against those things that have unfortunately been issues for a couple individuals. Any increased knowledge that we can bring to bear on those questions at this point, or anything you have to offer or say about that?
It's a great question. We're still trying to understand the kidney issues, and we have a really, really poor understanding, to be honest with you. I do have a kidney doctor here at MGH that's expressed interest into doing more research into it. But so far, we haven't really been able to provide her with more data yet. And I'm hoping that as we get more medical records and I can provide her with labs, both retrospectively and prospectively, definitely getting her involved during the prospective natural history and the clinical trial part of this, that perhaps we can understand a little bit more. I would say right now, the best things that we could do are monitoring, like you guys are with that cystatin C, and especially during the third decade of life. And if there is concern for kidneys not working as well as they normally would, then getting a kidney specialist on board. There would be nothing specific to ML4 to do, but all of the other supportive measures and any treatments that would be suggested just in the setting of moderate kidney dysfunction would be appropriate.
Thank you. In terms of meetings that we have coming up with the FDA, because of course the FDA is always interested in parent interaction. Is there anything else that you think we would need to supplement the sorts of records that we're collecting? Videos, things that parents can tape during therapy sessions, this sort of thing?
Yeah, thank you. No, that's excellent question. The very first preliminary meeting with the FDA is an interact, and it's brief and it's like a very preliminary one, so we wouldn't be able to share that with them. But following that, making it into the pre-IND and the IND meeting, I'm absolutely going to ask you guys for video stuff, and we're going to stitch and edit together some nice presentations to really illustrate to the FDA the challenges that our kids are dealing with, so that they can understand why we're proposing the endpoints for the clinical trial and the design of the clinical trial that we are. And I think it's going to be invaluable.
Yeah, we will definitely be reaching back out to you as we have up until now to demonstrate that. Diana has a hand up. Diana, would you like to ask a question? You'll need to unmute yourself first. Diana, can you unmute yourself?
Yes, there I am. In terms of the kidney function, my daughter has seen a nephrologist for a while, and they recommended her kidney functions were getting lower. They weren't norm, and few doctors recommended more fluids. So I know a lot of ML4 kids don't like to drink a lot. Certainly Ariel doesn't. And it was a back and forth. And then I finally had her had gastric tube put in, but with the express desire that it be only used for hydration. So that took a while of convincing the people who wanted to put it in, but she did get it because they wanted to feed her with the tube. So we did have the gastric tube put in. She's been using it for hydration for about 2 years now, and her kidney function went way back up. So eating a, very soft pureed food, but she's using the gastric tube for hydration and has really made a big difference. She does seem to have a lot more energy. She just seemed much better when she had it, and it was very hard for her to drink a lot.
That's so great. And thank you for bringing that up, Diana, too.
So-
I know gastric tubes, they're, it's invasive, it's a procedure, but in order to really reach like your hydration goals, it can be so useful, and it's so important to be getting the right amount of hydration and also nutrition too, as well.
Right.
And having it.
I'm sorry, I'm just going to interrupt for a second, which is terrible.
Oh, sure.
But one of my big hesitancies in having her have a hydration gastric tube was that the people presenting it were going right away from like hydration to feeding her. And I did not, it was like, oh no, if we put a gastric tube in, then we're going to feed her the Nestle, whatever, and blah, 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 blah. She doesn't weigh enough. And I just kept saying, well, let's give her more fluid and maybe she'll have more energy and she'll eat more. So it was very hard to convince these people of that because they wanted to jump right into the nutrition part. So I understand nutrition is very important, but I forced the hydration issue without the nutrition part, and it really worked. She started gaining weight, and she is still eating food. So that's something that parents come up against, where they want only part A, and then the clinical people are selling part A, B, and C.
I'm sorry to hear that.
Finally did it. I'm very glad I did, but it took me quite a while to do it because of that.
Okay, good. Thank you.
I usually in my own practice always think of it as like a safety valve thing too. Your kid can eat throughout the day and drink and whatever, and then whatever that deficit is, whatever you're thinking like, hey, they're not getting that much per day, you just make it up through the G tube. But it never has to be the sole way of taking in nutrition or hydration for sure. It's usually a backup.
Okay, I'm looking to see, just sort of playing cleanup in the chat room. So if anybody has anything else before we conclude, I want to be mindful of time. Janet, do you have something you'd like to ask? Just go ahead and take yourself off mute.
I just wanted to ask if this recording, the Zoom meeting, will be left on for any length of time after this so that people who are not able to attend could watch it.
Yes. So, Laura, it takes me a little bit of time to process this, but then what we do, as you will see on the website, is we have a section where Laura helps me produce these to a link where all of these are now archived. And we will send out the link where you can go and view these. So we'll send you a link where you can view them, and they will stay there for a significant period. They're archived, so you can go back and view them again. There were already some people who reached me in advance of this saying, I'm sorry I can't be there, but can I make sure to get a recording of this? And then for those of you who want to review this, can certainly go back and review this. And I will make sure that you receive an email with this link, and I will also post it on our Facebook page. Yep.
I just want to say that the things that I'm hearing here are so important for other families. And I'm sitting here thinking, oh my gosh, I wish Sandy and John were here.
Yeah.
Because Ryan has this problem and that problem, and I'm not going to be able to tell them.
Well, that's why we record this and make it available. I do feel like these conversations, there's a lot of collective knowledge. And of course, as rare as our kids are, they share so much, right? So getting together and having these collective conversations not only strengthens each of you because you realize that, you share a lot with other people when they're experiencing this and that, and the things that are sometimes maddening to you, finger sucking that you can't stop, a lot of other people are having going on, or whatever it is, you gain strength from that, but you also have access to Dr. Misko, who is such a champion for all of us. So that's why we make the recording available after. and you can watch it as many times as possible. So I will certainly make sure, of course, that they receive this recording and they can access it at their leisure.
Thank you.
I'm sorry, go ahead. I don't know who was talking. Okay. If there aren't other questions, then I'll bring this to a close. Yeah, Albert, go ahead.
I was just gonna say, so Yulia and I, along with Dr. Schiffman, actually wrote this like a review summary on the clinical management of mucolipidosis type 4. It's very technical, so I don't know how palatable it'll be, but you could also provide it to any of your clinicians or providers. I'm just gonna copy and paste the link right into the chat here. And you can feel free to, I don't know, either give them the link or you can print this out or even read it yourself too. I hope
You know
it's
what I'll
somewhat
do
helpful.
also, Albert, is I'm going to post it on the website.
Oh, great. Okay.
And I think you and I will talk. I know you're on service and you're going deep into the hospital to be untouchable for weeks now. But after that, we'll get together and talk about a checklist. And
yeah, it's fantastic. I love that idea.
we could do a little checklist in this review summary. That would be a nice little toolkit for people to bring to their clinicians. So that review summary that Albert just mentioned that was just published is very helpful for your doctors, and we'll also put together that checklist as well. And there will be more publications coming out as well. Albert is going to be publishing, more on the retrospective study going forward. I just want to conclude by saying that anyone we talk to in industry, these commercial partners and so on, is continually amazed and truly remarks on how terrific Albert is for this community and in the work that he is doing to bring this treatment forward. The combination of Yulia and Albert on the preclinical, creating the gene therapy, and the clinical side of understanding with a great deal of sensitivity and nuance and real compassion what's going on with your kids is like something you just do not usually get together. And that is how magic comes together. There's a lot of really hardcore science behind it, but you also really need a team that is really deep in belief about this. There is a lot of unpaid for time that goes on in this, and this is one example of it. So I just want to say on behalf of the work that I do, how grateful I am to have Albert as a key partner here. And so grateful for you. So just thank you so much. Thank you for showing up on your Sunday when you've got a million other things you could be doing. And
thank you guys.
So again, this will be saved and I will post it and let you all know when it's posted, and we'll get together again soon to continue talking and sharing and learning together.
Thank you, Rebecca.
Thank you,
Dr. Misko.
everybody.
Thank you.
Thank you,
Thanks,
guys.
everybody.
Thank you. See you
Thank you.
soon.
Bye.
Bye, everybody.
And thank you, yes, to Rebecca. Exactly, Tzvi.
Absolutely.
Thank you so much.
Absolutely.
Goodbye, everyone.
I'm happy to see your faces. I miss you all.
Always. I miss you too.
Say hello.
Stay away, but it's good to see you.
You're
You don't want to leave.
Look at that. She
I
has
don't want to leave. I
the
want to
best
see you guys.
smile.
I don't want to leave.
I know.
Becca. It's Anita.
Hi, Danielle.
Danielle.
I didn't see her there the whole time. Hey, Miss Smiles.
Hello, Danielle.
Hello. Say hi,
The
everyone.
best. Hi, sweetie.
What's going on?
Wave hi to Rebecca. Say hello. You've been listening to her.
Danielle.
Shy.
Danielle is not shy. I want my big smile. Tommy. Hello, mister.
Oh, look at these kids. They are so amazing.
I know.
Where's Danielle? She disappeared. Oh, there she is.
There she is.
Hello, sweet pumpkin.
Say hi to me.
Hey, Tommy, what a great smile. Are you guys on vacation, Joel?
Yeah.
Oh, wonderful.
Yes. We are connecting as we can via 4G because we've got no Wi-Fi.
Well, that's okay. I'm so glad you're using your 4G to come see us, but that's really, you look like you're having the best mood on vacation.
Aw.
So happy for you, Joel.
Hi,
Safe
Tommy.
travel over here.
Hello,
We had-
Rose. You saying hi?
Hi, sweetie.
Hi, cutie pie.
Oh, God.
Look at that face.
I know, right? That is.
We still have lots of COVID around here. We can't travel,
Oh, I
unfortunately.
know. It's really rough for you guys.
Yeah.
Also
Yes.
in Australia, you guys are really struggling.
Hi.
I've seen pictures of your daughter, Simonica, when she's younger, and some of the pictures really look like Rose.
She does, doesn't she? It's amazing. It's uncanny because I've seen lots of children that have exactly the same face. And
Yes.
your daughter is exactly like her. Paula, it's so wonderful to see you. I miss you so badly, love.
I can't wait to get together again. When is this happening?
Well, Rebecca, let's
Sandy
hope
and-
it's next year.
Yeah, we'll see. Sandy and Sasha, are you? Where are you guys at with vaccination? I was reading different things about Australia. Where's things at with you?
So most of my friends, including myself and Rhett, have had one vaccine.
Okay.
And in my second one's due next week. So we're pretty good.
Okay.
It's more anyone under the age of 30 and obviously the kids. So it'll be a while before, it's been going in generations, like 10 years. So
Yeah.
by the time it's available for our children, they reckon probably about the end of the year. We had everything under control, and it's just blown out recently.
I know.
So,
That's what I've been reading. That's what I've
Yeah.
been reading.
Yeah, it's
Yeah,
everywhere.
Australia was one of the safest
So our
places in the
blowout
world, so now it's
It
was.
trouble.
What?
What happened?
we had a limousine driver that was taking people from the airport. He contracted it. He wasn't vaccinated. We're a bit surprised why he wasn't vaccinated when he was working so closely with overseas passengers. And then our government didn't really lock down probably quick enough. In hindsight, it was the Delta strain, and I think she was sort of going off of the previous strains. So it's just blown out. Although when we say blown out, it's about 100 to 200 cases a day, which I still think is quite low compared to other countries.
Of course.
Sure.
Yeah.
Of course.
But this Australia went for eradication because we were so close to that rather than
Yeah.
reducing the number. The whole outlook, for some reason, that's the politicians, obviously that was the impetus. So we were just going down that pathway. So,
Yeah.
there hasn't, if there's a few cases, it's